So welcome everyone. Are you all from around or a little bit from all over the place? Good. Well, welcome to New York City. You picked a good week, and so I guess you already had a lecture this morning from Dr. Perezikian, and so you'll be, yeah?
An introduction. An
introduction. All right. And I'm going to assume that a lot of you know already something about bone because you're all endocrinologists or almost endocrinologists. I assume, and if there's anything not clear, then you can always reach out to me later on. I'm a clinical pharmacologist, as well known, and a clinical chemist. So I do a lot with pharmacokinetics of drugs in general, and some of it very specifically focus on bone. And so that's what I'm going to talk about, and how to talk about clinical and translational pharmacology in bone. A lot of pharmacokinetics and pharmacodynamics, but I'll promise I'll keep all the equations out of it. All right? All right, can I get the next slide? Maybe it's good to know the time of it. So I don't have to tell you about all of this, about the the various metabolic bone diseases, but the reason I'm showing that there are is because I took part of this presentation from another presentation, but also because various bone drugs that are used for bones are used for various of these diseases. So you can use, let's say, bisphosphonates are probably used for all of these, estrogens for some of them. Some antibodies are used only very specific rare bone diseases, but may also have use in certain of the others. So, and how you look at them, and especially when you try to figure out how to dose them, what kind of will be an optimal dose regimen, very often depends on what disease you're looking at. And so today I'm going to focus predominantly on osteoporosis. If you go to the next one. I don't have to explain this to you, but you will get a lot of this probably during this lecture. These are all these high-resolution PQCT images. I know very little of this, but still I can see that something is wrong there. And this is one of the ways of course, measuring the bone quality and what it looks like, and what the fracture risk would be from these. If you go to the next one. We have a definition of osteoporosis which precedes those other assessments, and I'm sure you're going to get a lot of discussion on this, on how those definitions actually came to be, and how they came to, for instance, T-scores of -2 and so on. That's all later on in this lecture. We're going to focus on drugs predominantly used for this disease. If you go to the next one. We have a lot of them, and there's a lot of them. There's quite a few in development, although you may have heard there's kind of a potential drought in anti-osteoporosis drugs. A lot of future drugs will probably come from the rare bone disease area, but these are some of them that we currently have for bone, or are in development. Still for bone. We have the estrogens, the SERMs, calcitonin, which are not really used a lot anymore, but we do have the bisphosphonates, rank ligand antibodies, which is, of course, you've used it. Cathepsin K inhibitors were in development until very recently. You're going to have a lecture from Aubrey Stock from Merck. He's going to talk to you about metastatic bone disease and cancer in bone, but I would urge you to talk about him also about the Cathepsin K inhibitor program that he led when he was at Merck, because he's a true expert and did fantastic clinical and translational pharmacology work there with the Cathepsin K inhibitors. PTH is anabolic, and we're going to talk a little bit about that, and sclerostin antibodies may be both, and I'm sure you're going to hear a lot from Dr. Perezikian also. And then we have some unknown. So the anti-resorptive, the anabolic, and the unknowns. If you can continue. Now, these drugs, especially the ones with the bisphosphonates and the denosumab, are very effective. These are some of the trials with Zoledronic, the essential pivotal trials for Zoledronic acid and denosumab, and you see that the risk the relative risk for whether it's vertebral fracture, hip fracture, non-vertebral fracture, etc., is all reduced by these compounds. So they're really, really effective. If you go to the next one, but if I see this in anything, then you can ask yourself, well, is this as effective as possible? I'm sure you've treated patients, or you're going to be treating patients with certain dose regimens that you think of, well, wait a minute, I don't think it's appropriate for this lady, or I don't think it's appropriate for this gentleman to be treating it this way, or this child to be treating it this way. So you can ask yourself, are they as effective as possible? If we would somehow individualize treatment of osteoporosis, that might actually lead to something better. If only to prevent side effects. You know, we've all heard from the osteonecrosis of the jaw and the atypical femoral fractures. I'm sure you're going to hear about that during this week too. You also have nephrotoxicity and gastrointestinal side effects, etc. All have led to alterations of dose regimens. So usually that means you try to decrease the exposure to the drug to limit the risk of side effects. And so what I'm always trying to do is identify optimal dose regimens for drugs, both those that are used clinically already, bisphosphonates, zoledronic acid, denosumab, and so on, or those that are in development. And you can think of things like Cathepsin K inhibitors or romosozumab, although I'm not even sure if it's still in development, or other drugs. You can think during the development process, we're trying to find out what the relationships are between the dose regimens and the endpoints, but try to find some biomarkers, also the effect of the dose regimens on the biomarkers that subsequently translate into the clinical outcomes, and how those relationships are for the various drugs and the various diseases. That's what a clinical pharmacologist does. Because basically the only thing, okay, you go to the next one, please. So my tunnel vision only allows me to think in PK/PD of pharmacokinetics and pharmacodynamics. That's the answer to everything in life. All the questions in life boil down to pharmacokinetics and pharmacodynamics. It's of course true. If you could keep on going. And it starts with, if you think about it, well, the pharmacokinetics, just to reiterate, I'm sure you've heard it 1,000 times and you forgot about it again, just like the Krebs cycle or the whatever. You hear it, you memorize it, and then when you walk out of it after the exam, you completely forget it. Pharmacokinetics is actually how the body handles the drug. So how is it distributed, how is it eliminated, etc., how is it metabolized, as well. And the pharmacodynamics is more what the activity of the drug is. Now, to study the pharmacokinetics, to study it really well, you need to be able to measure the drugs. And luckily for all those drugs, we have a whole bunch of various assays available. So for instance, for bisphosphonates, there are some ELISAs available for some of them. Usually they're in-house developed by pharmaceutical companies, RIAs, HPLC, LCMS. A lot of mass spectrometry is these days what we use to measure these drugs. Denosumab, Cathepsin K inhibitors, PTH, we have a whole bunch of them, and very often they give different results. So you always have to figure out, if you have a study, even a pharmacokinetic study done by one group and then done by another group, you can get differences in, for instance, things like volume of distribution or half-lives that may sometimes be related to the very assay that's being used. So it's good to keep an eye on that. But we have enough, so we can study the pharmacokinetics, and we can measure it in urine, in blood, as well as in bone. Although I've been trying both here as well as where I previously was in 15 years ago, but back in Leiden, or even longer ago, when I started there, to try to get bone samples to actually measure, for instance, bisphosphonates in. There's not a lot of clinicians that want to share their precious bone samples for me to ruin it and measure them the bisphosphonate in. But it is being done, and so we can sometimes also measure it in bone sample. We can especially do that in various animal models. If you keep on going. The effects, the measurements of the effects, so we can measure the pharmacokinetics. The effect measurements are fracture, bone biopsies, bone mineral density, high resolution PQCT. These and several others you're going to hear a lot for this these 2 weeks. The problem with that from a pharmacokinetic, from a PK/PD point of view, is that they're very slow. They respond very slowly. So, or they're very invasive for bone biopsy, or they're not readily available. So high-resolution PQCT instrument, there aren't that many centers around. And the one that reacts much faster and is relatively non-invasive, because you do have to get blood sample or urine sample, etc., are the bone turnover markers. You may already have seen this also. You have the formation and the resorption markers, the formation of the bone alkaline phosphatase, the collagen type 1 propeptides such as P1 and PMP1CP, and osteocalcin. And they're very established these days. And we have the resorption markers that are released during resorption. The most ones that we use used to be hydroxyproline, which actually works fairly well, pyridinium cross-links, pyridinolin and deoxypyridinolin, and CTX, or the collagen type 1 telopeptides such as CTX and NTX. If you can you go to the next one? So the last ones, for instance, just see they're these telopeptides at the end of the the collagen type 1. During osteoclast-mediated bone resorption, enzymatic work, the enzymes such as matrix metalloproteinase and Cathepsin K, they release them, these C and N telopeptides, and we have the various ELISAs that react with these peptides. They release into serum, and from there they are either further metabolized or renally excreted into the urine. And from this you can see that if you have an increased rate of bone turnover, you have increased serum levels. If you have a decreased renal function, you will, for instance, get decreased levels. This was the reason why we often correct them for creatinine. If you keep on going. Now, why do we like them? Not just because I like them because I make part of my living by measuring them, but also because they can be used as some form of biomarker. So, for instance, before treatment or without any treatment, they correlate, for instance, with bone formation rate or with actual bone turnover. So on the one hand, here you see the P1 and P levels. On this side, you see a bone formation rate in trabecular bone. This is from actually from a study with Tom Nicholas, who will be speaking right after this, in patients with chronic kidney disease, where we looked at the correlation between some of the bone formation rate from bone biopsies in correlation with the bone turnover markers. And you see that they correlate fairly nicely. This is actually a fairly high correlation for these kind of correlation, because usually it's more about 0.5. That's good to realize, because you may measure high bone turnover markers, but then when you do a bone biopsy, it may actually be low and the other way around, because this is just one side, and the bone turnover markers is a sum of everything that goes on in your body. But there is a correlation. So between the systemic bone turnover markers and the bone formation, bone turnover parameters as assessed from bone biopsies. They also say something about fracture risk. So these are all the studies from Patrick Garnero in the late 90s, where he showed that higher levels, for instance, of this is low turnover, high turnover, and what you see is that, let's say, low serum osteocalcin has a relatively low 4-year rate of bone loss, or high bone serum osteocalcin, or whether it's high serum P1NP or high urinary NTX or high serum NTX, coincides with a much higher rate of bone loss. So it says something about your chances to lose bone. And somehow it also tells us something about the fracture risk, independent of BMD measurements. So you have DEXA, you have high versus normal bone turnover markers increase the relative risk for fracture, and then both of them together, you get an even better one. Despite of this, it is not part of FRAX, for instance, because, and that has to do very often with the standardization of these bone turnover measurements. So if I measure them here, it's very likely that if my colleague down the road would measure them, we get different results. And these bone turnover marker measurements are not really considered a priority for proficiency testing programs. So if you do, then and we've been working on that to try to get them more standardized. And if they are standardized, then along the world, that's when they can be part of, for instance, something like FRAX, a tool to assess fracture risk. Can you go? Next one. So we can measure also these markers in serum or in urine or in plasma, and we can measure them, and we have a whole bunch of assays. We have a lot of immunoassays for instance, bone alkaline phosphatase, a lot of different ones. We have a lot of mass spec for some of the cross-linking molecules. You see that for everyone we have at least 1 or 2 or 3 or 4. Again, they give all kinds of different results. And that's because of the use of different antibodies, the use of different formats of the assay. And so you have to keep in mind again that if you have a study in front of you that measured the bone turnover markers and you have another study that measured bone turnover markers, you have to figure out whether they used exactly the same assay or whether there's a discrepancy between those two, because that can indeed explain a lot of the differences. Very interestingly, you will see this in the future, microRNAs, which become more and more, people become more and more interested in the use of these as bone turnover markers that also have an effect. But for now, it's just more in the experimental setting rather than in the, and that we're really using them for patient care. All right. Okay. Now, the bone turnover markers, very generally speaking, during anti-resorptive therapy and anabolic therapy, you get, if you give, for instance, 10 milligram zoledronate, it will go down, and then after a couple of months it reaches a max. Formation rates will follow and also decrease. The anabolic therapy will increase tremendously fast, and then that is followed by the resorption markers, and then they slowly go down, but then seem to not really normalize. Again, depending on what kind of disease you're talking about. This is intermittent PTH. This is a general picture, okay? Now, we like to measure them because, again, these bone turnover markers, the changes in the bone turnover markers, actually can also tell you something about the outcome then. So I leave out the changes in the bone turnover markers as from bone biopsies, but you may want to ask Dr. Rubin, Dr. Michela Rubin, about some of the correlation between the bone turnover markers and the changes that she sees in the actual bone turnover from the biopsies in her hypoparathyroidism patients, for instance. This shows you that the more decrease you have in serum anti-X, or the more decrease you have in serum CTX during bisphosphonate treatment, the more gain you will get in this case, vertebral bone mineral density. And this is measured 6 months after start of treatment, I think, on zoledronate. This is the other way around. P1CP, one of the bone formation markers, the increase measured 1 month, not 6 months, but 1 month after start of treatment, and then correlated with the percent change in baseline lumbar spine BMD. So percent change here and percent change there, and there seems to be a correlation between these two. So it also tells something for both for the anti-resorptive as well as for the anabolic one. You may be able to use this to see whether this drug will translate, or the dose regimen might translate into anti-fracture efficacy or gain in bone. Even anti-frac, there are some studies show with anti-fracture activity. This bone alkaline phosphatase, the change from baseline during, I think, a zoledronate treatment in patients with osteoporosis, and you see that there is a decrease in the odds ratio for vertebral fracture for those patients. Although that's a spline function, and to me it always sounds as if there's probably brilliant statisticians, but they can draw a line in everything. But I'm sure there is, and but there's much less literature out there that shows really that a decrease in bone turnover markers, certain bone turnover markers during certain treatment, actually really translate in anti-fracture activity. We have to be very careful. The evidence is not that strong, but of course, if you make your life measuring bone turnover markers, you like to forget about that. All right, so we're going to assume that that's just true. Now I'm going to talk about how we're going to do the PK/PD of certain compounds, and I love to talk about bisphosphonates, as some of you may know. Bisphosphonates, non-nitrogen-containing bisphosphonates, mostly what we're using is the nitrogen-containing bisphosphonates, Pamidronate, alendronate, etc., Zoledronic acid, central carbon atom, 2 phosphonate groups, side group. They go specifically to bone, to active remodeling sites, bind there, and then the side chain determines what the potency is and how they actually work. And this one makes sure that it actually connects even better to the hydroxyapatite. If you go, continue. If we give them to patients, then first of all, oral is very low bioavailability. Drink it with a little bit of milk and the F becomes 0%. If you give it that's why we give it sometimes intravenously. If it's systemic, there's almost no metabolism of bisphosphonates. And it very quickly disappears from the serum. Disappears meaning we can't really measure it anymore. So it very quickly becomes below the detection limits of our assays. Then it either goes to bone, to the active bone remodeling sites, or it is excreted renally. And so of every infusion that you give, about 50% goes to the bone and about 50% goes into the urine within 24 to 48 hours. In the bone it goes preferentially, but not only, to active bone remodeling sites. So if you have a purgetic lesion, then a lot of the bisphosphonate will go to that purgetic lesion, but not so much but it will also go to certain other places in the bone. In the bone it stays for a very long time, and from there, during subsequent bone remodeling, it will actually be released into the urine again. And if you keep on going. So this is some of a very quick study that we did with still back in Leiden, where we took urine from children with juvenile osteoporosis who had been treated with Pamidronate for a couple of years and stopped treatment, and a couple of years after the treatment we actually collected their urine. And we were still able to find quite some urinary excretion of Pamidronate in those. So this is very important, especially for the pediatric endocrinologist, that if you see if you start treating patients with bisphosphonates, be aware that they stick around for a very, very, very long time, and that could have consequences. Can you go back a little? No, back. Sorry. I think if you go, yeah. Oh. So the way we study the pharmacokinetics of bisphosphonates is we can, let's say after an intravenous injection, we can we collect blood samples. We will also collect urine samples. Those are the two ones that we can collect in patients. Serum, usually between 24 to 48 hours, it becomes below the detection limit. Urinary excretion from the first 24 hours or the first 48 hours, if you subtract that from the intravenous dose, then you will get a good estimation on how much exactly is there in bone, how much has been delivered to the skeleton. And then if you keep on measuring for much longer, up to a year, if not longer, after the administration, and you keep measuring it in urine, because there you can measure it for much longer time, you can actually get an idea on what the long-term release is of the bisphosphonate from those patients. So very similar to those patients. So when when you study the pharmacokinetics of bisphosphonates, if anybody of you ever has a chance to do that, or bone therapy in general, bone drugs that end up in bone, then be sure to collect both urine as well as serum for those drugs that are not metabolized, and make sure that you collect it long enough, not just all the way at the beginning, but long enough, because these drugs have very long half-lives. In order to determine them correctly, you need to measure them for a very long time. If you can, yes. So this is an example of exactly that, where in Leiden, and still some centers do this, they treat patients with osteoporosis or some other diseases with 5 infusions of Pamidronate for 5 consecutive days, 50 milligrams, 50 milligrams, 50 milligrams, 50 milligrams, 50 milligrams, every 3 months. And how you can determine the pharmacokinetics from that is that you first collect blood samples around the first infusion, second infusion. Then you take urinary excretion data, short-term urinary excretion data. You subtract that from the amount, from the intravenous dose, and that's when you get the amount attached to bone, and that's this. And then you can long-term, for let's say in this case 1.5 years after the dose, you can collect urine samples, and as long as you, if you add those all up, you will get an idea on exactly how much bisphosphonate is still at the bone, even 1.5 years after the dose. Okay? When we have that data, so short-term serum concentrations, short-term urinary concentration, and long-term urinary excretion data, we can describe those by these so-called compartmental pharmacokinetic models, or semi-physiology-based pharmacokinetic models, where you have a serum compartment, and from serum it can go into bone, to the bone surface. From the bone surface it can either get buried in bone and release very slowly, or it can go back and then excrete it into the urine. This is basically a system of differential equations that describes what the rate of changes of the serum concentration, what the rates of changes of the bone concentration. But for that, I would have to show you the differential equations, and I promise not to do that. If we go on to that, but the key is that from this data, we can determine with some with some software programs what these parameters, these various rate constants are, and volumes of distribution, etc. If you can go. That is the pharmacokinetics. For the pharmacodynamics, you can also take a look at in this case, some of the bone resorption markers. The time when we did these experiments, the late 90s, we were still using hydroxyproline as a bone resorption marker, which is actually a good resorption marker, provided you have the dietary, you make sure that there are certain dietary restrictions. When you start treatment in patients with osteoporosis and you give them this regimen that I was discussing earlier on, you see that it decreases, and it slowly increases again, and it decreases again after a next infusion cycle, and then again and again. But these changes, they differ when you treat more. If you can, yeah? Now that's the pharmacodynamic measurement. So what we were able to do with these so-called connecting the pharmacokinetics and the pharmacodynamics is by trying to take these average levels of the hydroxyproline and determine what kind of concentrations of the bisphosphonate would actually drive the change in those bone resorption markers. We were able to do that by also thinking a little bit about what actually happens with bisphosphonates. Well, they go to bone, and from bone they are actually taken up, and there they inhibit the bone resorption. So we were able to get the amounts of the bisphosphonate at the bone as well as buried in bone, and use 2 so-called Emax models, inhibitory Emax models. So where you have the concentration, and the higher the concentration, the higher the effect is, or the other way around, the more inhibition you have. And if we would link these to the amounts to bone, then we were able to describe these patterns of the bone resorption very well. And this is some of these parameters that belong to these rate constants, the volumes of distribution of the central compartment, as well as the Emax and gamma and so on. So the PKPD model. Once you have all that, that's when you can start simulating things. And simulating, I think if you look it up in the Webster Merriam or in the Oxford Dictionary or something, it would actually say on one thing, you can simulate it. Somebody can pull it up very quickly. I forgot. One of the things that is actually good use of simulating data, the other thing is that you might deceive somebody. So every time you read something about, hey, we simulated this, this is very likely that this and this is going to happen, be aware this is nothing but a simulation. It can give you an idea, but it has to be confirmed with real data. If you can continue. So here's some of the simulations that I did for Pamidronate. If I would give, instead of a 75 milligrams, I would give 45 milligrams. And this would be, as far as according to these models, the amounts of the bisphosphonate at the bone surface. This would be it if I would give 4 milligrams of Zoledronate. And Zoledronate, assuming that the physical-chemical properties of Zoledronate are more or less the same as Pamidronate, which is kind of true, but it's already an assumption. So you will get this amount of zoledronic acid at the bone, and this is the amount in the deep bone compartment. All right? So you say, so what? So what do I care? So if you go to the next one, if we would then put the PK/PD model, and we would put in remember we had the two Emax models, and we would play around with the potency of zoledronic acids, and we know that zoledronic acid, depending on what kind of in vitro model you're using, is anywhere between 25 and 700-fold more potent than Pamidronate in terms of inhibiting bone resorption. If you see that, then you see that in this case what the hydroxyproline would do, according to this simulation, is that it would decrease, and it would stay a decrease for a very long time after a single infusion of 4 milligrams. And we have the same thing, and this looks actually very much like the real data that were published by Ian Reid and colleagues, where you see urinary NTX and urinary CTX decrease after zoledronic acid 4 milligrams, and subsequently a prolonged decrease of the bone resorption markers. So this could have been predicted by these kind of simulations. But in this case, it was confirmed by real data. But it illustrates a little bit what you can do with these kind of PK/PD models. Okay? If you can. And this was not just done by a PhD student in Leiden, but it was actually done by real pharmaceutical companies. And this is, for instance, one of the simulations that was done by CTX of oral ibandronate during osteoporosis treatment. So at one time, people became very interested in switching from the daily treatment to either weekly or monthly or even yearly administrations. And when they do that, they use these kind of models that they also develop for ibandronate as well as for all the other bisphosphonates. And then they could get an idea, okay, if I switch, then what will be from the daily one, then what would my CTX look like if I would, in this case, for instance, go to a monthly? And this kind of data gives you a little bit more support on, oh, it might actually be worthwhile doing a phase 2/3 trial with 150 milligrams daily, because it's very likely that this kind of pattern looks similar and that it leads to anti-fracture efficacy. Okay? All right, let's go on to the next one. Now, the key of the bisphosphonates, this is the slide, and again, you're going to have a talk from Aubrey Stock, and you should really ask all about Cathepsin K to him. The key is bisphosphonates. This is an osteoclast resorbing bone with its precursors and so on. The bisphosphonates are at the bone, and there's some beautiful fluorescently labeled pictures from Graham Russell and the groups from Oxford and Aberdeen, where it's taken up into the osteoclast during bone resorption. But it has to be at the bone and buried in bone before it is actually taken up into the bisphosphonate. Cathepsin K inhibitors, Cathepsin K is one of these enzymes that is secreted into here, but Cathepsin K doesn't go to bone. It is there, but it doesn't bind to bone. It doesn't preferentially bind to bone because it doesn't have these two phosphonate groups. So the relationship between, if you measure in serum and Cathepsin K inhibitors, is probably more direct than with serum concentrations of bisphosphonates and bone concentrations of bisphosphonates. So I don't know if I explained it correctly enough, but for all our efforts to measure or to understand the pharmacokinetics and pharmacodynamics of bisphosphonates, we do a lot of effort. We put a lot of effort in describing the concentrations of bisphosphonate at the bone. For Cathepsin K inhibitors, from the way we know how they are distributed, that might actually be a little bit different. It might actually be a little easier to some extent. So this is Odanacatib, one of the Cathepsin K inhibitors. You probably can't see it, but it's a rather, we call this a small molecules, but it's a rather small, it's a rather large one. It doesn't have two phosphonic groups, so it doesn't bind to hydroxyapatite. So that's step number one. It is metabolized relative to, if you compare to bisphosphonates, it is metabolized to various metabolites. And I don't know if some of them are pharmacologically active, probably one or two is, but I'm not 100% sure. They are metabolized, and then they are excreted either into the urine or through biliary excretion and then enter hepatic reuptake. So you can measure the various metabolites in urine, in feces, as well as in serum. And so that's a difference between these drugs. If you can keep on going. When they started looking at the PK/PD of Odanacatib, so to try to find out what would be the best dose regimen to do their phase 3 trials with, is the first what they found out was that it actually has quite a long half-life, not as long as bisphosphonates, but 60 to, I think, 80 hours or something, which is good enough to give this drug as a once-weekly administration. So you see, here you see the levels after a single dose, for instance, of 50 milligrams of bisphosphonates, of Cathepsin K inhibitor. This is the pharmacokinetics. This is the pharmacodynamics. So after CTX levels change from baseline during various doses. 5 milligrams, it goes down very quickly and then it comes back up again. First of all, it goes down very quickly, which doesn't happen with bisphosphonates unless you give a really high dose. So bisphosphonates first have to go to bone and then be taken up, but the Cathepsin K inhibitors work much more quickly. Their effect, however, is also resolved much more quickly after you give it. So after you stop it, within no time, the bone turnover markers go up again. So there's probably a much more direct relationship between the serum concentration of the Odanacatib and the changes in the bone turnover markers. And so you can actually see this. This is the Odanacatib plasma concentration. This is the CTX level. And they could find from here these nice Emax models again, which is very similar to this one. So you can use the serum concentration, the plasma concentrations of Odanacatib to predict what kind of a dose regimen you would need in order to get continuous suppression of bone resorption markers. Does that make sense? Oh? All right. So completely different. Going back to the bisphosphonates, and because so a lot of those slides were from the late 90s, early 2000s. You think, well, we've heard about all of that, and very exciting stuff on the bisphosphonate, or at least I think it's exciting, is that they're now using bisphosphonates more to target drugs, other drugs, to the bone, and those can be used for drugs that. Let me first go on. So this is a study from USC, from Parrish, in collaboration with Hal Ibertino, who used to be I think the head of medicinal chemistry at Procter & Gamble, Charles McKenna, who synthesizes all these drugs, and Graham Russell for Oxford. They designed a bisphosphonate linked to ciprofloxacin. So if you can keep on. what that does is, here you see a bisphosphonate, here you see ciprofloxacin, here you see a chemical linker that's, and because of this, because of the bisphosphonate, this conjugate goes specifically to bone, and then to a site where there's active bone remodeling, in this case to an osteolytic infection site. Because there's a low pH there, and because they make the linker strategy as such, and they release the active drug at the bone site, so you get active bisphosphonate or non-active bisphosphonate, as well as active antibiotic, and that's exactly what you need in order to treat osteomyelitis. Right? This is pretty neat, and this is for an antibiotic, as an example, if you can keep on going. And they've been doing it for and other groups too, for antibiotics, especially for osteomyelitis, for cancer, so to treat metastatic bone disease, for multiple myeloma, for others. So there's also bisphosphonate conjugated to bortezomib, as well as even bone certain bone diseases, such as for osteoporosis, to bring drugs to target them specifically to bone and make sure that they systemic levels are much lower, which prevents the use of certain drugs. What we're doing now here is we're setting up or gearing up to do the PK/PD experiment with bisphosphonate conjugated drugs in animal models. So what we do is very similar to what I do, and hopefully one of you will one day also do this. You give the drugs to either animals or humans, you measure the drugs and the biomarkers, you do these PK/PD analysis, and that, if you start it in animals, you do it in various animal groups of species, gives you an idea on what dose you need to do for phase 1 and what dose regimen, and then together with the first human data, you can try to think on, all right, what dose regimen do we need to get in order to get to phase 2 and 3. All right? If you keep on going. Now, I told you in the beginning, what we do for the bisphosphonates is we take a lot of effort, we put a lot of effort in being able to estimate what the concentration of the bisphosphonates at the bone surface is, because that's where it's working. In this case, for instance, with ciprofloxacin, to treat osteomyelitis, it's also very important to find out what the concentration of the ciprofloxacin is at a certain time, and whether you can get an idea on how much there will be in time, and when do you need to give another dose, and when do you need another dose, and how can you measure it, or will you just be guessing to get the best out of it. So what we're trying to do now is do these experiments with, again, short and long-term serum, urine, and bone concentrations of both the conjugate, this bisphosphonate with the ciprofloxacin, as well as the bisphosphonate itself, as well as the ciprofloxacin, and then see whether we can use these kind of models to describe this. And let me take you through these models. This is nothing but 2 of these compartment models that I've shown you for Pamidronate. This is one, a bisphosphonate. You had your serum compartment. I probably should have put that. Oh yeah, you have your bone surface compartment, a deep bone surface compartment, a serum compartment, and urinary excretion of bisphosphonate. Where does this bisphosphonate come from? It is released from a bisphosphonate conjugate at the bone surface. From the bone surface, these conjugates can be buried in bone, and they come there through the systemic circulation. And it's very likely that the conjugates behave very similar to the bisphosphonates. From here, you give an injection of these conjugates. They go to in the systemic circulation, might be excreted in urine, might be metabolized. Then they go to a bone surface. From there, they might be buried. From there, they are released either into another bisphosphonate, as well as the ciprofloxacin at the bone surface. And that's exactly what we want to do. And from the bone surface, that ciprofloxacin might then go to a systemic circulation and be redistributed again, because we know what ciprofloxacin behaves like when you give it as ciprofloxacin itself. Okay? And so, if you can keep on going. This is, for instance, according to these models, is a simulation. And again, all the caveats of simulation. And did anybody look it up already, what the definition? There you go.
It said to give or assume the appearance or effect of, often with the intent to deceive, or to make something such as a physical system.
Thank you. So this is not to deceive, just so that you know. This is the serum concentration according to these simulations of the ciprofloxacin bisphosphonate conjugate. So you see, very similar to what you see with bisphosphonate, you see a very rapid decrease of the serum concentration of the conjugate, and then a very long half-life. If you can go to the next one. After I made up that I would give 75 milligrams. This is the ciprofloxacin concentration in serum after the administration of 75 milligrams of the bisphosphonate ciprofloxacin conjugate. So you see that it, according to this model, it goes up, 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 and then it starts going down. This is the serum concentration. Fairly low serum concentration, but we might just be able to pick it up. How fast this happens actually is determined by the pharmacokinetics of the bisphosphonates, the pharmacokinetics of the ciprofloxacin itself, but very important also the release kinetics of these bisphosphonates. And so if it's released faster, this will go forward, and it might even get a little bit higher. So, okay, but we can only find that out when we do actual experiments, if you keep on going. The good thing, according to our models, is that when we measure something in serum, this is the ciprofloxacin bone surface amount. According to these models, it's very similar, and the shape is very similar to the ciprofloxacin concentration in the serum. So if we measure it in serum, it is very likely that we're going to get some information of the ciprofloxacin at the bone surface. Okay? So this is according to these simulations. This is true for ciprofloxacin, or at least according to the simulation. This is not so much true for another of these conjugates, bisphosphonate with bortezomib, where the kinetics are different. And we can measure the bortezomib in serum all we want, but it probably doesn't say anything about the bortezomib at the bone. And so we have to find something else. So I invite you all to ASBMR this year, then I'll probably present a little bit on this. So hopefully not only have simulations and deceit and so on. So this is used for infectious disease, for metastatic bone disease, and so on. And this is the real reason why we do this. That might improve the translational development, because we will sooner or later get the very same problems with these drugs as we had with the bisphosphonates. Where in the beginning we always thought, oh, they're safe, we have no problem, etc. And then eventually, oh shoot, there's these kind of side effects, and these kind of side effects, these kind of side effects. Maybe we should give less, and how do we give it less? Okay? All right, I have, if you can keep on going, I'll try to throw in a little bit on PTH. So you're going to hear a lot of about hyperparathyroidism from Dr. Bilezikians. I'm not going to tell anything. But even I can see again that primary hyperparathyroidism is probably not good relative to the control. You also have the opposite, hypoparathyroidism, where and I'm sure Dr. Rubin will tell you more about it, where this is thick, the cortices are thicker, and it's much thicker bone because there's no PTH, or virtually no PTH. And then treatment of osteoporosis is actually treated with intermittent PTH. But treatment of hypoparathyroidism, we also treat that with intermittent PTH. So what is good, it becomes very difficult. And if you have too much, continuously too much, you have bone loss. If you have too little, you will have lots of bone also. If you give intermittent, you will have growth of bone. But if you treat somebody the hypoparathyroidism with intermittent, and it's also not good. Very interesting subject, and I'm sure you're going to ask Dr. Bilozikian a lot about it. If you want to read a little bit more about this, then I suggest you do this. What I wanted to show you, and just for the sake of time, I'm going to skip through these. These are some of the results of osteoporosis in hypoparathyroidism. Sorry, next one. And the point is, in hypoparathyroidism, patients are treated with intermittent PTH, and you see that it's working really well. So the calcium levels in the hospital administrations, etc., go down. But at the same time, you also get like a large increase in bone, at least, except for the radial bone that actually loses. You see the bone formation markers go up, and they stay a little bit up, as well as the resorption markers. So it works to some extent, but it's very likely that you can benefit from a different mode of administration. It's very likely that it's more for hypoparathyroidism, you want to have a continuous administration of PTH rather than injections. If you can keep on going. This, obviously, we never think of things, but in this case, I think at the NIH, they looked at this already in the past with the effect of administration of PTH as a pump. So that's very interesting. And it shows that it's feasible. You can get an insulin pump and administer PTH, and that works. Now, if you look at the administrations, on what PTH levels actually look like in patients, and these are some very old studies, again, where they did a lot of measurements of PTH at the same time. You see that there's a circadian variability. So, but there's also spikes on top of it. So you have a circadian variability, but you also have these spikes. And so you might as well take your pump and then try to mimic that. Now what we then do is take, develop PK models for subcutaneous PTH, which you can derive from data that we have ourselves, as well as data from, that are available in the literature. Again, calculate these kind of parameters, and then simulate again what PTH might do, in order to get a first idea about, all right, what do I need to do in order to simulate those levels? And if you can continue, then these are some of those simulations that we tried to do there, is where you see, we know now, if our simulations are correct, that we can have certain pump rates where you can mimic circadian variability, and that on top of that you can actually get some peaks from such pumps, and you may just be able to pull this off. And so this is the first suggestion that you can probably mimic the circadian variability and the pulsatile PTH levels during that are normal. So this would be good for a patient with hypoparathyroidism, but of course this then needs to be really confirmed in real patients, and probably preferably first in healthy volunteers or something. All right? For those of you who like this, I'm sure you all do, I would like to refer to two things that are coming, and that are either just published or have been used already. There's one very recent paper in the Journal of Clinical Pharmacology that came from FDA, and FDA is very keen on these kind of PK/PD simulations. And they actually allow you to use a lot of data that's already out there in order to bridge certain studies, so that you don't have to do a phase 1 study or don't have to do parts of phase 2 studies and so on. And so I advise you to look into this paper, Regulatory Perspective and Pharmacometric Models of Osteoporosis. And the second one is a themed issue that we're working on a paper that I'm an editor of the British Journal of Clinical Pharmacology, where we're trying to get this, but we're doing it on a much larger scale. We got a lot of different diseases where we discuss the clinical and translational pharmacology of drugs, And those include a lot of rare diseases and a lot of different drugs. But that is to come in Q3, Q4 of this year, if everybody is on time with submitting their papers. So thank you very much, and that's it. Any questions? Yes.
Have you, have you worked with PTH on fracture healing, or what is your opinion?
You want to talk to Dr. Bilezikian about that. But it has been, and I believe we even at one time tried to put in a grant for the Department of Defense to increase fracture healing for soldiers when they're broken. Then we can put them back into the battlefield as quickly as possible. Because that's the kind of grants that they will actually fund, but it didn't get funded. But there's quite a lot of knowledge. I have no idea about the PK-PD relationships or the clinical and translational pharmacology in that for fracture healing. Nothing. Anybody else?
Is there any particular animal model that you would recommend for a PK-PD study?
It's a very good one because, first of all, a lot of the animal models animals have different kind of bone turnover, so it's not always good. So if you do it, you have to use a couple of them. I have very little experience actually in animal models, but usually when I really want to look at data that is relevant for humans, and you want to go into the vertebral monkeys, etc. That's usually the thing that says most about what will happen in the patients. The problem is that those usually only get published by the time they also publish the rest of the data. So, but that is essential. Yeah. Anything else? No? All right. Thank you.
Thank you.